All right. So let's get started. Hello and welcome to our first Lunch and Learn of the year, the launch of the 2026 to 2030 Nevada Cancer Plan. This session is being recorded. We'll archive it on our website and our YouTube channel. We've chosen to host this session in the meeting format, which allows anyone to unmute themselves and ask questions, which will give us, and we'll have time at the end for a more engaged discussion. NCC staff members are monitoring the chat and raised hands, so we're happy to answer questions during the presentation. However, if you can otherwise mute yourself, that will ensure that we don't have audio disruptions. So let's get started. I'm Kristen Hackbarth, Communications Director for Nevada Cancer Coalition, and it was my pleasure to lead the development of this newest edition of our statewide cancer plan. So this plan is a framework for action developed by more than 100 volunteers from across the state, working in clinical and public health settings, survivors, caregivers, advocates, policymakers, and others. This is really the largest group of people that we've had participate in development of a cancer plan to date. It was really amazing to see all the different people come together at in-person meetings, on Zooms, in work groups, and really hammer out the details of this plan. They use the most recent cancer data from our Nevada Central Cancer Registry, along with their expertise to draft goals, objectives, and strategies that will help us to make progress in reducing the burden of cancer in Nevada. So I quickly want to note that this plan focuses on evidence-based strategies designed to make sustainable changes in the areas of policy, systems, and the environment. So just to quickly recap what those are, policy change involves creating or modifying laws, regulations, or even organizational policies to support healthy behaviors and reduce cancer risk. So examples like might include a tobacco-free workplace policy or legislation that increases access to cancer screenings. Often policy change is necessary before systems or environmental changes can be implemented. Systems change focuses on altering the rules, structures, or processes within organizations or communities to improve cancer outcomes. So that might involve integrating cancer screening into routine healthcare visits or using electronic reminders for vaccinations. Environmental change modifies the physical or social environment to make healthy choices easier, such as building safe walking paths or increasing access to healthy foods. So there's a misperception that the cancer plan is intended to guide the work of the Nevada Cancer Coalition staff. And to a certain extent, that's true, but it's so much more. Comprehensive cancer control is an approach to reduce the burden of cancer by coordinating collaboration between partners. More simply put, it's people and organizations working together to achieve outcomes we could not achieve separately. That being said, everyone has a role to play in Nevada's plan. These are photos of some of the groups that participated in an activity outlined in our last cancer plan, even if they didn't know they were doing so. People who can use this plan can include local, state, and federal policymakers, educators and students, community programs, yes, even parks and recreation people, physicians, hospitals, health departments, and cancer survivors. Nurses, nonprofits, business owners and leaders, pharmaceutical companies, and yes, even the Burning Man camp that wants to ensure their fellow burners are sun smart. The cancer plan is a public health strategic plan, but it's also a guidebook with activities that anyone with an interest and the initiative can take up and execute in their communities. So, what is new in the 2026 to 2030 Nevada Cancer Plan? This plan still prioritizes prevention, screening, early detection, survivorship, and surveillance and research. Those are things that were at the heart of our last plan, and we kept those in. But we've expanded and recognized some of the objectives. I'm sorry, we expanded and reorganized some of the objectives. We now have a goal and objectives addressing genetics, primarily related to cancer risk, diagnosis and treatment, which focuses on access to quality care, and pediatric and adolescent and young adult cancers. This plan is more comprehensive than ever before, and we've delved deeper into cross-cutting issues, speaking more to concerns including housing and food insecurity, access challenges for our rural and frontier populations, our public health and overall healthcare infrastructure, and the many environmental factors that affect Nevada, including radon, mining, and urban heat islands. The plan shines more of a light on how changes to policy affect cancer control in our state and also provides more policy-based strategies at the state and local level that can be pursued to achieve our goals. And one of our wishes from the past plans, this time we worked directly with tribal, LGBTQ plus, and rural and frontier communities to get direct input into the barriers and solutions to cancer control for them and their communities. We took into account 4 key things when working with partners to develop this new plan. Is the need for each objective or activity supported by the data? Can we measure progress on it? Are stakeholders supportive, and were they able to contribute to the development of the objectives and strategies to make them meaningful and effective? And lastly, is what we've proposed even achievable? Do we have the capacity, the will, and the funding to make it happen? And I'm happy to say that a lot of what we put in the plan is, I would say everything we put in the plan is achievable and based in data. So I wanted to explore the data with you. This is really what inspired the plan, all of this data. And so I'm going to click through into our online virtual plan where there's some interactive data. And then I'm also going to showcase some of the data that we used to develop the plan that isn't necessarily included on our website. There is so much data that we used that it's just would be too overwhelming to dump it all on everybody all at once. But we'll dump it on you right now. And feel free to stop me and ask questions along the way because there's a lot of information here. So we'll start off. This is our online virtual Nevada Cancer Plan. And this is the section that really talks about the data or the cancer burden through data. So we learn a little bit more about people of Nevada. You'll see this has been a trend for quite some time, but fewer than 50% of our communities in Nevada are non-Hispanic white. We have a larger percentage of people who identify as non-Hispanic or something other than white. So cancer incidence and mortality in Nevada. We can see that in Nevada, we have a slightly lower cancer incidence, but about the same, or maybe slightly higher mortality than the US as a whole. We know that men are more likely to be diagnosed with and die from cancer than women. And we see that Black people are more likely to be diagnosed with cancer than any other race in Nevada, and they are also more likely to die from the disease. So we looked at the trends of cancer incidence and mortality, which haven't changed too much. They're pretty flat. And we looked at the leading causes of cancer and the leading causes of cancer death. And if you look at this, obviously breast and prostate cancer are the most commonly diagnosed cancers in Nevada. Lung cancer, however, is the leading cause of death. There's a big mortality disparity here. And that's one of the reasons why our partners really are focusing on increasing lung cancer screening, because we know that as screening improves and more lung cancers are found early, we can bring this number down and save more lives. So these are some of the other cancers. Obviously, colorectal cancer is always in our top 5 for diagnosis and mortality. We also have pancreatic cancer is really high, is among the higher in mortality. And then we have some other cancers that aren't really screenable, and they're not necessarily top in incidence, but they do cause a lot of deaths. And that's liver and bile duct cancers, ovarian, leukemia, non-Hodgkin lymphoma, urinary bladder. And then we've got things like melanoma, where we focus a lot on melanoma. We've got a couple of different objectives in the plan related to that, because we know it's a high incidence. And even though there's not a high mortality, that incidence does have an impact on people's lives. And so we want to focus on that. For the liver and bile ducts, we did add that into our nutrition section for prevention, looking at heavy drinking and trying to educate people about the role of alcohol in cancer risk. So we also looked at the leading cancer diagnosis based on gender so that we could make sure we were capturing that. So for, again, looking at melanoma, Men have a higher rate of melanoma than women, and it's the number 4 diagnosed cancer among men right now in Nevada. So that's another one of the reasons why we wanted to focus efforts and activities on sun safety. Um, so again, this is the most commonly diagnosed or the top mortality by gender. And lung cancer, again, is leading. And there's a disparity here with men. And so we need to focus on, again, the screening. Here's another chart that we looked at. This is cancer rates by incidence by cancer type and by race and ethnicity. And you'll see here, this is where we found a lot of information for racial and ethnic disparities. So for example, Black people are much more likely to be diagnosed with prostate cancer than any other race. And so in the past, we've never included anything about prostate cancer in any objectives for prostate cancer in the plan because it's not necessarily recommended for screening on a regular basis like other cancers are. However, we included it this time because there are disparities here. And here's another look at that. And this is the same thing with mortality rather than incidence. And again, there's that prostate cancer mortality that's a disparity among Black men. And so that's that one. And then I wanted to go in, here's another, so all of that data is available on our cancer plan website. So here's a little bit more data that I want to show just quickly. And again, stop me if you have any questions, but this is some of the data that we used to evaluate what we wanted to look at for early detection and access to care that really has to do with stage of diagnosis, because we know that if we have great early detection, we can catch more cancers in those earlier stages. We don't want to see late stage diagnosis. Oh, sorry. Whoops. There we go. Go backwards. Back. Sorry. There we go. Okay, so stage of diagnosis. So from the Nevada Central Cancer Registry, we received this data and we're happy to share any of this data with anyone if they'd like to have it. But what we're looking at here is the light blue is early stage diagnosis and the purple is late stage. And then the gold is an unstaged. And at times that's because we don't have great data or the patient wasn't staged, wasn't ever staged. Perhaps they didn't seek treatment, or perhaps it was sometimes the cancer registry reports cancer cases based on death notices. And so they may not have a stage at diagnosis because they didn't have that treatment data. So what we're looking at here is that lung cancer is overwhelmingly diagnosed in the later stage, even though there is a screening for this cancer. And again, that's one of the reasons why we wanted to focus so much on increasing lung cancer in this plan. We included it in the last plan, but there's a lot of opportunity here to reduce those late stage diagnoses. You can see here with breast cancer, we have screening and we promote screening a lot. And so we have more of those early stage diagnoses. So this again is a look at early stage versus late stage. This is just lung cancer. And I wanted to show a little bit about why we didn't do a lot of geographic breakouts on some of the components of the plan. And that's because we don't have vast differences geographically for a lot of these things. I think that there's kind of a misperception that our rural communities are struggling and much worse off in terms of cancer diagnosis. But that's not necessarily true when it comes to staging. Across the board, lung cancers are diagnosed at a later stage. When we look at race and ethnicity, it's also very similar that across the board, lung cancers are diagnosed at a later stage. And I think that that's really the same for a lot of the different cancers. So we can look at liver cancers, um, largely diagnosed at a later stage, even in our urban counties. It's when you're looking at Clark County and you're looking at all of the rural and frontier counties, and they're almost the same. This isn't necessarily an access to care issue so much as maybe perhaps a prevention education issue. And then we look at race and ethnicity, and again, it's very similar across the board. And so we don't see a lot of disparities there in terms of diagnosis. Again, this isn't a screenable cancer though. So
And Kristen, on
yeah,
the graphs that are through our website where you can get to those, are you able to switch between region and ethnicity as well? Or are those graphics just already in there?
these ones do not have that switch out.
Okay,
The data on these ones does not have that.
okay. So what we have online is what we have online.
Correct.
Okay.
So another cancer that we included in the plan this year, not necessarily with objectives, but we included narrative because we want to bring awareness to it, is lip, oral cavity, and pharynx cancers, which are the head and neck cancers. And we know that those are increasing. Many of them are caused by HPV and some also caused by tobacco use and alcohol. But we know that these are screenable through oral exams by a dentist, and yet we have a really high rate of late stage diagnosis. And so we wanted to draw attention in the plan because we know that more people getting screened with oral screenings, we can kind of flip this and get more people diagnosed at an early stage. And again, it doesn't really discriminate based on race and ethnicity. Um, Everyone's getting diagnosed at a later stage. Well, not everyone, but a lot of people are getting diagnosed at a later stage for these head and neck cancers. And so we need to draw attention to that. Breast cancer looking a little bit better by region and also by race and ethnicity. Not a ton of differences here. Colorectal cancer. This is another one where this is a screenable cancer. And so ideally, you'd want to be seeing early stage diagnosis higher than mortality or than late stage diagnosis. And we're not seeing that. And so again, this drives home the importance of focusing on colorectal cancer screening. This is the race ethnicity. And then when you look at it by region, a lot of our rural counties don't have gastrointestinal doctors. They don't have GI docs. They don't have colonoscopy centers. And Clark County and Washoe County do, and yet we're seeing the same rate of late stage diagnosis regardless of geography. And then again, same thing for cervical cancer. Race and ethnicity, not really that different. And geography, not really that different either. And so when we look at that, we know that we've got some rural disparities in terms of, we have fewer providers in rural Nevada, but we're seeing the same things regardless of where you are. So I wanted to quickly go through this as well. These are charts that we probably won't share, but we needed to look and see like where are our disparities? Because if we look at the stage of diagnosis and if we look at the incidence of mortality, it's a little bit hard to see where our disparities are. And so we did kind of a ratio of different race ethnicities compared to white people. So white people would be the baseline. And we wanted to see, are Hispanic Nevadans more or less likely to be diagnosed with these different types of cancers? And we found that when it really comes based on the data from the registry, stomach cancer is really the only cancer where there is a statistically significant increase in incidence for people who are Hispanic, um, which was fascinating. And when you look at mortality, Hispanics have a much higher mortality from thyroid cancer, stomach cancer, and Hodgkin's lymphoma, which I think is really interesting, but all of these other cancers, breast cancer, lung cancer, they are less likely than white people to die from those cancers. So we did that for each of the different races. For Black Nevadans, we have major disparities for people who are Black in Nevada, much more likely to be diagnosed with prostate cancer. And the asterisks here at the end of the cancers note that these are statistically significant differences. So Black people are statistically more likely to be diagnosed with prostate, breast, colorectal, uterine, myeloma, liver cancer, stomach cancer. Um, so those are all disparities that we need to look at. Why are they being, what is this a genetic issue? Is this a screening issue? Um, and then again, we've got the mortality, far more likely to die from prostate cancer than whites. Um, Same for breast cancer, colorectal, uterine, pancreatic, multiple myeloma, stomach cancer. We looked at Native Americans. Again, the liver cancer is a really big one here for this community, and also kidney cancer, but less likely on some of our other major cancers. So breast, prostate, lung, colorectal, less likely to be diagnosed. And then mortality, there's less data available simply because of data suppression in the registry. But again, mortality from liver cancer is statistically more likely for Native Americans compared to non-Hispanic whites. And so again, this is one of the reasons that we wanted to include drinking in the cancer plan as part of our prevention. And then one more trot through the data. We wanted to make sure that we looked at some of the other factors that play into this, not just the cancer registry data. So looking at our behavioral risk factor surveillance system, we know that Nevadans are far less likely to be, well, not far less likely, but somewhat less likely to be screened for cancer than the average US adult. We have been among the lowest for screening in lung cancer. And again, this low screening rate really ties into um, our increased, higher late stage diagnosis and our higher mortality. So one of the things that I wanted to highlight, and I know that this map is huge, so we can't look at the whole state at the same time, but I wanted to point out that there is a bit of a interesting thing happening where we think that in rural Nevada, we have much lower screening rates because there's less access. And that's not necessarily true. So if we look at screening rates across the state, the lighter pinks are a lower percentage of women screened, and the darker pinks are a higher percentage. And granted, it's between 67 and 75%. So it's not a vast difference, but it's a difference. And it's an interesting difference based on the fact that in Humboldt County, it's a very rural county. And you've got Washoe County, which is urban, and for the most part has quite a few screening centers, and yet it's among the lower screening rates in the state. You've got some of these other rural communities that have better screening rates for mammograms than our urban communities. Clark County also low in screening. And so looking at that, we need to put work in to understand how our counties that have no fixed screening locations, or maybe one fixed screening location, seeing better screening rates than our urban communities that are chock full of screening locations. Again, the same thing for colorectal cancer. I think just because you have colonoscopy centers in your community doesn't necessarily mean that your screening rates are better than the rest of the state. If we look at the state as a whole, it's almost entirely the same color of blue. It's all lower in screening rates. And really, the only county that seems to be excelling somewhat in colorectal cancer screening is Douglas County. And Douglas County is consistently ranked among the healthiest counties in the state and has a much larger population of older people and wealthier people. And so that potentially could contribute to higher screening rates just in that county. But again, it's consistent across the board that we have lower screening rates. This isn't necessarily a geographic issue. So one of the other things that we included, not necessarily with objectives and activities, but we did do a call out in our new adolescent young adult section, is early onset colorectal cancer. And if you look at the starting rate in 2010, 9.8 out of 100,000 people ages 35 to 44 were diagnosed with colorectal cancer. And in 2022, that jumped to 17.9%. That's almost a doubling of the rate of people 35 to 44 diagnosed with colorectal cancer. And that is the decade before you are eligible to be screened for colorectal cancer based on USPSTF guidelines. And so we did a call out in the plan because we know that this is increasing. And until our screening recommendations change, and if they ever do change, we need to make sure that we're talking to people about genetic testing and genetic risk and family history for this type of cancer so that we can make sure that the people who are at higher risk for getting early onset colorectal cancer can get in to get screened. We looked at the same thing for breast cancer and early onset breast cancer, and we didn't see this level of trend. So again, when we look at disparities in terms of access to care, we can see that the darker yellow are people who it's a higher percentage of people who are living in health professional shortage areas. And so we can see that aside from Elko and Clark County, the bulk of the state is almost entirely a health professional shortage area. And so we need to focus. This really pinpoints the fact that we need greater workforce development, and we need workforce and facilities in our rural communities, but also our urban communities. Washoe County, Carson City, Douglas County, they all are facing major healthcare provider shortages. Physical activity declining as it gets older. And so one of the things that we included was some physical activity guidelines and we shifted away from focusing on obesity to focus more on nutrition and physical activity in this plan. We also looked at socioeconomic factors. And this map, again, it's not unlike the colorectal cancer map in that when we look at socioeconomic factors, we've got similar situations across the state, regardless of county. You can see that none of these are necessarily standout, but this is the percentage of people who are uninsured in Nevada across the state. We've got food insecurity, and food insecurity is relatively consistent across the state. We've got Esmeralda and Mineral County, which are very frontier with the highest rates of food insecurity, but overall, it's fairly consistent. The same goes for housing security, fairly consistent across the state. And so when we look at things about how they affect Nevadans' health, we know that these social determinants of health really are affecting people regardless of where they live in our state. Same thing for transportation barriers. Fairly consistent. And you'd think that in Clark County, we wouldn't have those kind of transportation barriers. Same thing for Washoe County, where we have transit. And we have less distance between facilities and where people live, and yet we still have these transportation barriers. And then again, the lack of social and emotional support. We see that a couple of our rural counties have a higher rate of lack of support, but it's across the board. And in some communities, it's worse. I mean, Clark County is very urban, and yet it has the same lack of social support as White Pine County, which includes Ely and is pretty darn rural. So that's a look at our data. We also used some qualitative data and data from other sources that weren't cancer specific. So we looked at things like strategic plans and policy reports. We looked at food bank data. We looked at news articles. We looked at USDA, Department of the Interior data to get information on what really is driving and affecting cancer in our state. And we used all of this data to really with stakeholder input, put these things into the cancer plan. So, for example, we know that liver cancer is among our top 10 incidents in mortality, and there are racially based incidents and mortality disparities. So, and there's no screening test. So, we added heavy drinking indicators and activities to our prevention section. We know that incidence and mortality and late stage diagnosis, along with early onset, exists for several cancers with genetic risk factors. And so we added the genetics section and an objective like for prostate cancer to make sure that we were able to address that. Our data really was limited for pediatric cancers, but for precisely that reason, we developed an entire section to address pediatric and adolescent young adult cancers in the plan. And then finally, based on a broader evaluation of cross-cutting issues, we addressed more of those issues and took them into account as we developed activity sections, activity suggestions for each objective. So we also expanded other parts of the plan, including a more robust discussion of disparities and health equity, more discussion of clinical and community research and data collection, additional narrative and objectives for workforce development, and more discussion of access to healthcare. One thing we also talked about really was public health infrastructure. I think over the past year, we've really seen threats to public health infrastructure and concerns about funding and concerns about workforce. And so we included narrative about all of that so that it can be taken into consideration as we're exploring these objectives and activities. So how do we put the plan to work? There are a ton of different ways that you can use this plan. And really, this is just a list of opportunities that's at the beginning. So we'd love to hear about what anyone's doing related to implementing the plan. I know it just came out, but I wanted to share a few specific examples of how activities that we've written into this new plan are already being executed. So we have doctors working to educate other clinicians to increase HPV vaccination, which is exactly what we wrote into that plan. Educate clinicians on evidence-based strategies to increase HPV vaccination. We have clinical and public health partners promoting fitness and providing exercise amenities and sunscreen at community locations. Renowned Health installed fitness courts at multiple area parks. We've got Northern Nevada Public Health sponsoring anything but the gym fitness. Comprehensive Cancer Centers has been putting free sunscreen kiosks at locations throughout Southern Nevada for a number of years. We have survivor advocates and physician champions that are hosting community forums, going on news interviews, educating the community about cancer prevention, early detection, and survivorship. We have universities that are publishing data on healthcare workforce and other factors, and then elected officials like Senator Rosen that are pushing for policies at the federal level, some policies at the state level to aid workforce development, bring more doctors, bring more medical students, bring more nurses into the state. Couple others. We've got the NCC this month. We are actually launching a cancer navigation community of practice to increase patient navigation in our state. And that checks off multiple boxes of activities within the plan. We're working with research partners to establish a cancer research network this year. And then we've got pediatric partners who are collecting and sharing data on out-of-state travel, provider workforce, and they're working together to really map out what the landscape of the pediatric oncology workforce is and where patients have to go to get treatment. So those are all activities that are already underway that are written into this plan that just launched. So now's the time when we can get going and start executing this plan and move ahead with accomplishing all of the goals and objectives that we have outlined. So with that, I'm going to stop sharing my screen and open it up to see if anybody has any questions. I know that was a lot of data to drop. And we've got the whole NCC team here, so if you have any questions for any of our team members, throw those out as well.
I'm wondering if we could share a couple sections from the PDF and what will be in the printed plan, just so everyone can see what that looks like.
Sure. I think the printed plan is beautiful. Let me get that shared here so you can, and I'm going to make my screen smaller. So this is what the new plan will look like. And again, you can see just how many people contributed to the development of this plan. It's an amazing list. So the new plan will have, this is a lot of stuff we went over. We have progress from our last plan. We've got a lot of the data. So the data that I showed you, the first chunk of data that I showed you, we do have in the plan. It's not interactive, obviously, because it'll be printed. But this is the same data that we have on the website. So you can review that. And we have all of our cross-cutting issues, a lot of narrative really talking about that. One of the things that I didn't mention too much is that we talked a lot more about cancer in the environment in this plan than we have in the past. And I think that that's been the case for other states. We know that Iowa uses a lot of cancer in the environment. Alaska has an environmental group that they work with. But for us, we haven't really looked at that. And I think that it's important for us to think about because with increasing wildfires, with increasing heat, and with industries in our state that could potentially pose a risk with agriculture and mining and gaming and the carcinogenic exposures, um, we thought that it was important to highlight that. And so we do have a couple of pages just talking about that and the environmental exposures. And then, of course, we can't forget it's Radon Action Month, and
Yeah.
radon is one of the environmental causes of cancer. Um,
Well, I think that's an area too that we're looking at more policy in because Nevada really
yeah,
doesn't have policy related to radon and new house builds and things of that nature. I
yeah,
mean, we've been very successful in the last few legislative sessions with actually moving forward bills in the cancer realm. So that's one area that we can certainly move the needle on, and some of these,
yeah.
yay, all our sections.
So these are all the sections, and each one is color coded a different shade of green. And in those sections, you'll find some additional data and then all of the objectives. And the way that we've structured the plan is similar to how we did it the last time around. So we have our goal section, and each goal section has objectives and strategies. And then indicators. And the indicators are what we're going to use to measure our progress towards our objectives. And so, for example, percentage of 9-year-olds receiving at least one dose of HPV vaccine. We have our baseline and our target. And that's the case for all of our different areas. We've got more focus on physical activity and nutrition, again, heavy drinking. So all of the sections are somewhat similar to this in looking at kind of the different high points of each section. Got we have a lot more data in this plan than we did in the past. But I think one of the things, and I think this is something that Amy has done in the past, is she actually took her printed cancer plan and put Post-it flags all over it to flag out different areas. And I think that that's a really great opportunity is to kind of look through and flag the different strategies that perhaps are things that you can implement or work towards or talk to people about. Um, for example, radon. I think that you know, radon gets talked a lot about at this time of year. And obviously, this is the best time of year to be testing based on guidance. But these are things that we can be focusing on year round. So, supporting policies for radon resistant construction, talking to developers, talking to different policymakers to see how we can kind of move the needle on this year round. Sun safety. Um, and this is one of the ones where I think we have a lot of community activity regarding sun safety. I mentioned the people who were heading out to Burning Man and wanted to know if we had sunscreen that they could take along and hand out to other people at Burning Man. And I think and we have college students who have done sunscreen drives to gather sunscreen so that we can provide them to students at Title I schools who are part of the SunSmart Nevada program. And so I think there are some of those things that can very easily be completed by anybody can go out and do these sorts of things and incorporate cancer control into their daily activities. Um, Carrie, was there anything else you specifically wanted me to highlight?
Not necessarily. I just wanted to give everyone an idea of how the plan is set up. Um, and then you mentioned like the policy strategy.
Yeah.
And I don't know if you want to go back up to any strategies in the early detection realm.
Yeah, we can. So a lot of the strategies for breast, cervical, colorectal, and lung cancers are very similar. And so we lumped all those together. We have separate indicators for each of those that you can see here at the bottom, but we have largely the same strategies to increase screening for those four cancers.
Mhm.
And so we included those here, and that's, even something as simple as recognizing and promoting cancer awareness months. We know that talking about cancers can help to destigmatize them. Just last week, we spoke with a cervical cancer survivor who said that, a lot of people don't want to talk about it, that there's a little bit of a stigma with cervical cancer which hadn't really, that was a little bit of a surprise to us, but I think, she knows her community and so even just recognizing Cervical Health Month every January can help start a conversation a little bit more. Um,
One of the other big strategies in this area that we've really leaned into is the improving access to cancer screening within a community. So, in other words, being in the community where people work, play, worship, and actually taking screenings to them, or at least talking about screenings with them. Lung cancer screenings hard to do out at a park, but we can certainly get the mammo van places. We can hand out fit kits. We can talk to them about lung cancer screening and get them screened and signed up to go and get that low dose CT. So this is an area a lot of our partners have been working in and partnering with us on, from hospitals to community clinics to all kinds of partners in this realm. So that's another strategy. But again, it takes all of us working together. Obviously, the coalition doesn't provide screenings. We set up the opportunities in the community and then bring our partners to the table to do that.
Yeah, and I will note, I'm going to stop sharing here, but I will note that for almost every area of the plan, we do have a collaborative or working group. And so anyone can join those work groups or collaboratives and work together with us on achieving these. So that's definitely an opportunity where if you're interested in getting involved, you can do so. Any other questions?
Quick question, Kristen. Excellent job, by the way. This was
Thank you.
so professionally and so well done, and there's so much data driving where you guys are going. It's really great to see. Um, when you went through those dynamic graphs. Is
Mhm.
that linked on the website? Because obviously it's not going to be dynamic in a PDF or paper form. So what you presented early on with the data and what you guys were seeing, is that available at your site?
The first chunk of data that has the basic incidence and mortality,
Yes.
that is available on the website. We did not include all of the subsequent ones. So all of the charts related to stage of diagnosis, the social determinants of health, and some of um, the incidence and mortality ratios. We did not include those online simply because it would be, I think, a little bit overwhelming to dump all of that out there. However, we do have that data. It is published and available, so we're happy to share it. And we also are using some of those charts as kind of special features throughout the year. So, for example, this month is Cervical Health Awareness Month, and we put out a resources in January with quick facts about cervical cancer, and we include data on that page. So you'll find that stage of diagnosis data in that cervical cancer page. So those are included in other areas of our website, and they will be added throughout the year. But we didn't lump them all into the online version of the plan because we thought that we might blow your mind too much.
Great answer. Thank you.
But yeah, all of this data is public and available from the Nevada Central Cancer Registry. So we're happy to share it, and that's what we really want to do because we want people to be able to understand the real landscape of cancer in Nevada. Any other questions? Well, I have to say that, working on this plan is truly a labor, and it's a labor of love. And so we want to thank everyone that contributed to the plan. And we will be doing outreach throughout the year. So we want to be getting this in front of as many people as possible. So business organizations, policymakers, city councils, health districts, different organizations. We want people to be using this plan. This isn't just for the Nevada Cancer Coalition, and it's not just for necessarily people who are members. It's for anyone who lives in Nevada. And so if you know of anybody or any groups or any individuals that should be connected with the cancer plan and learn more about it, please send them our way. We are happy to arrange virtual sessions or go to them and provide presentations and work with them on what they might be able to contribute to reduce the burden of cancer in our state. Well, if there's no other questions, I will give everyone back their next 10 minutes of the hour. And thank you again for joining us. We appreciate it, and we appreciate all of the support that we received in launching this 2026 to 2030 Nevada Cancer Plan. Thank you.